You guys are making excellent progress. I mean, you got a great facility, you got a great community, you've got vibrancy within the county, and you've got a great track record of restoration for the stability of this entity, as well as physician recruitment. You've got a lot of things going for you. I think tonight is also a very important, if you will, touchstone on which you will need to strengthen what you've got and go forward. You cannot rest on your laurels. You've got some good progress, you've got to keep making it. Your role going forward is really, as George Bush said, I'm the decider. Well, you guys as a board, you're the deciders. You decide on the strategic direction. You decide on the amount of money that it's going to take to get there. You decide on the quality of the staff that you're going to bring to bear. And you're going to decide on how we're going to monitor this. You don't do it, but you do monitor it. You are responsible for it. You have a fiduciary as well as a strategic responsibility. Those are basically the two responsibilities any board has. And so what you bring to bear is that. How you do that is reflected in this little questionnaire problem I've passed down. So those of you who are kind of in the middle, kind of go either way, that's great. If you find yourself on one extreme or the other side, ask yourself, why am I there? And what is it about that that makes me fall on a 10 or a 1? Because that is what you bring to bear. And you may need to think that through as you interact with other physicians, or you interact with other board members, or board members interact with physicians and vice versa. So part of this is agreeing among yourselves to be part of the dialogue, because that's what it's going to take. It's an iterative process. By the end of tonight, there's not going to be a cookie cutter recipe. There'll be some suggested goals that I have for you. And you guys need to process that and say, that's the ones we can endorse, because you are the ones who are the deciders. So, let's go. The lay of the land. It's real this time. We've had a lot of things over my career about healthcare change, because everybody says we need to have healthcare change, and I've got a slide in here to show you exactly why we need it. The healthcare reform legislation is basically in 3 parts. But you'll notice below, we also have 3 parts if you look back at our history. The 60s to the 80s, cost, building boom. I mean, we were getting lots of money flowing in the system, and we built lots of buildings. I mean a lot of buildings. We built a lot of beds. And everybody was going to the hospital because that was the place to go. Then in the next few years, everybody's favorite president, Ronald Reagan, brought DRGs into place, which is a form, if you think about it, a bundled payment. It's a process of taking thousands and thousands of different component parts and pieces and putting them in diagnosis-related groups, which is a bundle. So the first bundle payment was right here. That brought down length of stay, increased outpatient growth, but payments started going down. So now we've had all of this stuff going on just in the last 2 or 3 years. And where is that going to take us? Well, we're going to talk a little bit about that. So, back to the reason for healthcare reform. This blue line here is an important line. That line has been growing at 2.5% per year, every year, for the last 20 years. Now, I heard the Finance Committee say something about CDs and things and trying to get 0.75. But you got 2.5% for 20 years in a row, every year. We wouldn't have to worry about this. That's what it's growing at. And that's why all of this stuff came into place. Healthcare reform's goal is not 0 cost growth. It's 1% cost growth. 1% is the equivalent of the gross national product. So all that whole effort, this very complicated effort, is trying to do is get us back into the norm with everybody else. So that's why there's such a hue and cry for this. Again, the 3 pieces. rules and regs. We've been in the rules and regs stage for the last 3 years. This is what it is. You're going through it right now. The program, if that's for me, would you tell them? I'll be with them in just a minute. The program is not a government-run program. It's a government-regulated program. Primarily, every initiative that's going to take place is right here. Health insurance companies. And all the debates, and anybody, if you can give me an example, I'm going to write it down. And all the debates leading up to 2010, which was the passage of the legislation and law, so in 2008, 2009, did you hear one concern expressed by any health insurance company? Not one.
Only when the public option was on the table.
Yeah, because they were going to get opted out.
They were going to have competition.
That's right. They're happy with this. They're happy with 30 million more insured clients. They're happy with the ability to use ACOs and value-based purchasing, and they're happy to use bundle payments, and they're doing it now. Okay, so basically 3 tranches of care. Rules and regs, basically we're in that now, sort of shaping the landscape again. Then the next tranche will be adding folks in play, and that begins January 1 next year. Then the new normal. My prediction is that will be really 2020. I think 2017 is a stretch because the current Congress is underfunding the implementation schedule. So that's the way to control it, is you just don't pay anything to have it happen, and it won't happen. So it'll take longer, and therefore it'll give us more time to adapt, and we probably need more time. This is a very aggressive process. Shell game volume is going to go up, older populations, more people are covered, price is going down, costs are going up, and that's what it looks like. Simplifying the complex. These are just boxes, and some of them already exist. There's a process in place to make all that work together. It is going to be difficult, to put it mildly. This is another chart. I love this chart if you could see it, but you can't. Each one of these lines is an activity related to getting to health consumers. So there's a payer line, a physician line, a provider line, and a pharmaceutical line. And basically, it parts out each piece of the law and when it goes into place by year to bring it to bear as to bring it into effect. That shows how complicated this is. There are thousands and thousands of people trying to deal with understanding of where we're going. For you guys, as a tax-exempt hospital, there were some specific requirements. You've already done these. Community health needs assessment, you had to comply with that. Patient financial services requirements, you had to comply with that. There were bundling and capitation demonstrations, one of which was right up the road in San Antonio Baptist. So there's a lot of things going on. There's a map I'll show you later on that illustrates that. The rural hospital exceptions. There are specific rules, and there may be more regs to be written, because remember, the legislation is one thing. The regulations can also get lobbied and changed and modified as we go forward based on the facts as we stand going forward. So this is important. The whole hospital exception for physician-owned hospitals is over. Existing physician-owned hospitals, restrictions. Rural hospital physicians subject to whole hospital restrictions, it's over. However, there are new models that incorporate physicians.
Can you talk about what that means? What is that whole hospital exception for physicians?
There used to be an exception. If a physician group or an individual physician owned an entire hospital, they were exempt from some of the restrictions on physician ownership. That was an exemption. That ended. And the reason it ended was because over time they saw that physician-owned hospitals had higher rates of admission and longer and higher costs than did hospitals that were not owned by physicians. So, and then,
And is that, there's sort of a phenomenon of some hospitals open for physicians that don't participate in government programs? Does that affect them as well?
if they don't accept Medicare, they would be outside of this.
Okay.
But most insurance companies follow Medicare rules, and so it's going to be very difficult to operate. However, if a physician is a minority owner of a hospital, there may be a way around it. We'll talk about that a little bit later. So, there are cards now that say, good luck with the American healthcare system. I will also tell you that what we are now going through, there's 137 countries in the world. Only 2 of them have the system we do. And so, and we're one of those 2. Most of them have a standardized one system, one activity, one function fits all. And it seems to work. Because our health statistics are still 17th or 18th in the world. We are still, though, number 1 in cost, by far. Our GDP for healthcare costs is 17.8. The next nearest countries, there are 3, at 9%. Japan, Switzerland, and I can't remember the 3rd. But we're almost double the next nearest country. So,
Is that malpractice?
it has nothing to do with malpractice.
Nothing? Everything includes the
No,
cost?
malpractice is like an infinitesimal % of the cost.
So what he's saying is, in this country, we spend twice as much on healthcare, and our outcomes are like 20 in terms of life expectancy, infant mortality, percentage of our children who are immunized. We could just go on and on and on. Every industrialized country in the world gets better healthcare than the United States, and we're spending twice as much.
I think a lot of those countries that you mentioned don't report the same things that we report, and therefore the system.
I don't know.
It's the World Health Organization survey. I think.
Well, it's the Organization of European Common Market. That's one of the ones that reports Japan. Some of these are very sophisticated countries. I mean, very highly industrialized countries. So I'm not sure I agree with you. We've looked at these statistics for 10, 15 years. They're pretty well. Okay, I do want to focus on these 10 areas. These are the areas for which you need an understanding over the next 3 to 5 years. You'll see themes in here that basically will tell you where things are going. I suggest you take notes if you want to have some part of the dialogue later on in the meeting tonight. You can take notes right on the slides there, ask questions or whatever, but we're going to go through this relatively quickly so as to be on time. Medicare and Medicaid will hold payment constant. That's after the 2% reduction we just experienced from the sequester. But the cost per unit is going to go up, and those are the reasons why. Provider focus is on, make a note, clinical integration. Lean is a term used in management circles for kind of efficiency in processes and the way things go from that. The key here is the width of the triangle at the bottom of the picture. And note the increasing need for access points to service. Make a note. I'm giving you some hints. You will not be at this level. You just won't be there. But you will be here, and you should be here. You should be very, very focused here. And that is something about increasing your population. It does not mean increasing use of inpatient beds. It means increasing the population that you serve. Define how you serve them is something yet to be done. Physician alignment is key. Physician alignment in everything is key. one of my partners in this company is right here, a guy named Tom Royer. He's a doctor. He's boarded in emergency medicine, boarded in surgery. He was rated the 7th most influential physician in the United States about 5 years ago. He wrote me an email just 2 days ago. He said, there's a new day dawning. The physician voice is being heard. And I wrote back and I said, you're an idiot. I've been listening to doctors for 40 years because doctors make the decisions. But he's right in the sense that if physicians are not heard today, if physicians are not at the table with the decision makers, i.e. the deciders, then the best care won't go on. And this is coordination of care. The only people who can coordinate care are clinicians. It's important that they sit at the table. We're going to talk about the patient-centered medical home in just a minute. I mentioned models. This is a model for physician alignment. It's one that we did when I was at Christus several times by specialty area. Physicians are at the table. Physicians actually make the management decisions on how the particular program, that we did it for cardiology and orthopedics and various others. So this is commonly used. There used to be some different funding for this kind of thing than there is today. However, it still brings about improvements in clinical quality and safety, and that's one of the measures which influences reimbursement. You've got to have docs at the table to make sure that the quality stays high. So the patient-centered medical home, basically 7 principles. Anybody, when they were a kid, ever see Dr. Welby? Well, you know, you got him. He can do all this stuff. The key here is it's the focus on the patient. And the 3 areas of focus are the patient experience. So what you'll see is a theme in here, 3 areas of emphasis as we go forward: cost reduction, increased quality and access, and improved patient experience. All of that has to come by providers, those who pay, and the patient working much more closely together. These are the unfortunate statistics associated with it. I say unfortunate from the provider perspective. Anybody bothered by these?
You mean from the hospital?
That's right. Well, the provider perspective. Because a really well-run primary care medical home may reduce the number of referrals to a specialist. I.e. the last point, 15% reduction. When I was in Seattle for a meeting, and I visited with a large medical group there, which had just received, well, just a couple of years prior to that, had received 660 patients from Boeing. Boeing had 19,000 employees down in their operation, and you multiply that by 3 or so. So they had a number of folks. They were all self-insured. They were totally self-insured. And of that group, of that very large group of 40,000 or so people, they had 660 frequent flyers. I mean, they could not keep these people's costs down. They went to this medical group and said, if you'll take them, we'll create whatever you ask, if you'll be the concentrated provider. And of this group, which was 54 docs, kind of spread around the Seattle, Tacoma area, they said, yeah, we'll take it. And they negotiated a price. And within the space of a year, they cut the cost of those 660 by $1 million. Almost 98% of that came out of Swedish. Swedish is the local hospital. Swedish said, oh yeah, we'll work with you. We're going to work with you. The medical group itself added not one doctor. Not one. 660 new patients, no new doctor. They added 3 psych nurses, a pharmacist, and 2 people in home health.